Hello, my name is Santosh Abraham. I'm working as a specialist registrar in endocrinology and diabetes at Scarborough General Hospital. Today I'm going to talk to you about SGLT2 inhibitors and the mechanisms of their cardiovascular benefit. So this is based on the journal publication from Diabetology. So I've given the web link here. SGLT2 inhibitors reduce the cardiovascular events primarily through prevention of heart failure, and this concept has gained broad acceptance, but there are several questions to be answered, and the most important is how. These are the putative mechanisms underlying SGLT2 inhibitor associated cardiovascular benefits. The first one is a reduction in preload due to natriuresis and osmotic diuresis, and afterload due to reduction in blood pressure and improvement in vascular function. This will result in improved ventricular loading. The second mechanism is improvement in cardiac metabolism and bioenergetics. The third mechanism is by myocardial sodium exchange inhibition. The fourth mechanism is reduction of necrosis and cardiac fibrosis. And fifth mechanism assumed is alteration in adipokines. This is what happens when you treat the patient with SGLT2 inhibitors. This is what happens to the nephrons. So prior to treatment, you have the dilated afferent arterioles and dilated fibrotic loops through which the protein leaks, and after treatment with SGLT2 inhibitors, there is afferent arterial constriction and there is decreased intraglomerular pressure, leading to decreased proteinuria. So SGLT2 inhibition definitely improves ventricular loading conditions. This is one of the main mechanisms why which SGLT2 inhibitors exert their beneficial actions. This is secondary to reduction in preload because of the diuresis and natriuresis. SGLT2 inhibition happens in the proximal tubule. So here salt and glucose is excreted and there is osmotic diuresis, and this can be favorable to the heart of a diabetic individual. So can diuresis really explain the benefits when other diuretics have not changed the prognosis in heart failure? With dapagliflozin, a reduction in plasma volume and increase in erythrocyte mass was noted with the trial. But with both the agents, which means that the diuretic and the dapagliflozin, there was associated reduction in sodium and interstitial fluid, but DAPA produces these effects with little or no change in blood volume, whereas the diuretic is associated with greater reductions in intravascular volume. In patients with heart failure, there is intravascular contraction, and it is aggravated by diuresis. The ability to selectively reduce interstitial fluid is a unique feature of SGLT2 inhibitors over other diuretics, and this will limit the reflex neurohumoral stimulation that happens in response to intravascular volume contraction. Another difference is that conventional diuretics and SGLT2 inhibitors have different effects on uric acid levels. SGLT2 inhibitors are uricosuric, while loop diuretics increase the uric acid levels. So this could probably affect the cardiovascular outcome. SGLT2 inhibitors improve endothelial function and aortic stiffness indices. and may potentially induce vasodilatation through activation of voltage-gated channels, potassium channels, and protein kinase G. SGLT2 inhibition has been found to improve cardiac metabolism and bioenergetics. Substrate utilization is greatly impaired in diabetes. The substrate utilization of heart is greatly impaired in diabetes. So it is assumed that an over-reliance on NEFAs as a substrate for ATP generation will result in a buildup of FFAs, that is free fatty acid and their intermediates, and it will in turn promote lipotoxicity, impair sarcoplasmic reticulum calcium uptake, and will lead to the development of diastolic dysfunction. This is what it is assumed if you have a ketotic like picture. But what happens with SGLT2 inhibition? In fact, SGLT2 inhibitors increase the production of the ketone beta hydroxybutyrate. Beta hydroxybutyrate will be an alternative and less expansive myocardial fuel source. In fact, it is a super fuel that is oxidized by the heart in preference to NEFAs and glucose. NEFAs means non-essential fatty acids. It improves cardiac function and also it increases the mechanical efficiency of the heart. Also, increase in beta hydroxybutyrate will inhibit histone deacetylase and will prevent pro-hypertrophic transcription pathways. Increased beta hydroxybutyrate has also been found to decrease acetyl coenzyme A supply. This will reduce harmful hyperacetylation of mitochondrial enzymes, thereby providing mitochondrial energy production. Branch chain amino acid degradation is known to be impaired in heart failure, and this will contribute to aberrant myocardial bioenergetics. SGLT2 inhibition promotes branch chain amino acid degradation. Therefore, thereby it provides an alternative fuel source for the failing myocardium. What is the effect of SGLT2 inhibitors on sodium hydrogen exchange in the myocardium? It will directly inhibit the sodium hydrogen exchanger NHE1 isoform in the myocardium. In heart failure, activation of NHE1 results in increased cytosolic sodium and calcium, and it will in turn cause intracellular hydration. So SGLT2 inhibitors will promote natriuresis, and by down-regulating the activity of NHE3 in the proximal tubule. So the expression of NHE3, which mediates tubular sodium reuptake, is increased in heart failure, and the inhibitory effect on NHE3 may serve as an additional mechanism to restore whole body sodium homeostasis and reduce cardiac failure. Thus, inhibition of NHE1 and NHE3 may be common cardiorenal mechanisms through which SGLT prevents and treats heart failure. In short, it is by direct inhibition of the sodium-potassium exchanger NHE1 and by down-regulating the activity of NHE3 in the proximal tubule. This is what's happening when the NHE in the myocardium is blocked or inhibited. You can see the sodium and the calcium concentrations decreasing inside the cell. What is the impact on cardiac fibrosis? So it is widely regarded as a common final pathway through which heart failure develops. This involves structural remodeling of the heart due to deposition of ECM matrix proteins, and these are laid by cardiac fibroblasts. It will result in impaired ventricular compliance and speedy development of heart failure. DAPA has shown to suppress collagen synthesis by activating M2 macrophages and inhibiting myofibroblast differentiation. EMPA attenuates TGF-beta1 induced fibroblast activation and also extracellular matrix remodeling. EMPA also suppresses expression of key profibrotic markers like type 1 collagen, alpha smooth muscle actin, MMP2, etc. So glyphylosins suppress collagen synthesis and also fibroblast activation and also expression of key profibrotic markers as well as extracellular matrix modeling. Therefore, an emerging postulate is that SGLT2 inhibition, independent of hyperglycemia, may have direct and favorable effects on cardiac fibroblast phenotype and function, one of the most factors of heart failure. What about the impact on adipokines? Ectopic fat deposition in the form of perivascular and epicardial fat has been implicated in the cause of heart failure. SGLT2 inhibitors may mediate their benefit by restoring the balance between the pro and anti-inflammatory adipokines. They are postulated to reduce the levels of leptin, which has a pathophysiological role in sodium regulation as well as cardiac inflammation and fibrosis. A marked reduction in the inflammatory cytokine IL-6 was also observed in this study. So these are the mechanisms by which SGLT2 inhibitors have a favorable cardiovascular outcome. So I will summarize again by going back to the slide. So these are the mechanisms. Again, a reduction in preload secondary to salt and glucose loss through the urine, and a reduction in afterload due to reduction in blood pressure and improvement in ventricular loading. That is, this preload and the afterload improvement will lead to improved ventricular loading. There is an improvement in cardiac metabolism and bioenergetics through beta hydroxybutyrate. There is an inhibition of the myocardial sodium exchange inhibition transporters, and also there is a inhibition of the sodium hydrogen exchange transporter in the proximal tubules as well. And they have shown to suppress fibroblast proliferation and also other stimuli which will increase the cardiac fibrosis. Also, they have shown to decrease the levels of leptin, that is adipokine, and also other interleukins and cytokines. Thank you for watching this presentation.